Hey everyone, welcome to this explainer. If you're a student in the Medical Record Diploma program, listen up because this is specifically for you. If you think you're just training for a standard run-of-the-mill clerical job, think again. Let me tell you right now, in healthcare, information isn't just data. It is a vital clinical resource. You are stepping into a high-stakes role where administrative efficiency literally supports clinical skill.
I am absolutely thrilled to guide you through this today because we're going to decode the essential operations of medical records. We are talking about becoming the true gatekeeper of information. It's a big title, right? But your actions, your organization, your precision, they directly impact patient outcomes. So let's get focused and look at how this all actually comes together.
Okay, here's your roadmap to becoming a highly reliable healthcare professional. We've got 5 stops. First, the information gatekeeper. Second, ethics and fiduciary duty. Third, architecting the medical office. Fourth, real-world process engineering. And finally, advanced troubleshooting tactics. So let's kick things off with Section 1, the information gatekeeper. To truly wrap our heads around this role, we have to look at the medical clinic through the lens of systems theory. Basically, think of the office as this massive puzzle of interacting, moving parts. A single documentation failure doesn't just, sit quietly in a file drawer. It ripples out and impacts the whole patient care process. Take medical transcription, for example. It's not just typing out voice recordings. It is formally defined as the transformation of clinical intent into legal record. You are literally translating a doctor's critical clinical decisions into legally binding documents. That is a massive responsibility. There's this really powerful quote from our source text that hits the nail on the head. It says, "The medical secretary should be the gatekeeper of information, collecting information properly, storing it safely, and retrieving it promptly." This right here, this empowers you with your core professional identity. You are the ultimate protector of information integrity, because without your diligence, the clinical side just cannot function safely.
Moving right along to Section 2, ethics and fiduciary duty.
Stepping into the shoes of a gatekeeper requires a rock-solid commitment to a strict ethical code. It's way more than just doing paperwork correctly. It's about honoring the patient. Take autonomy, for instance. That means ensuring the minimum necessary disclosure under HIPAA rules, basically respecting the patient's right to control their own health info. Then there's beneficence, acting in the patient's best interest. In your day-to-day, that translates to verifying lab result accuracy so care is actually safe. Non-maleficence, doing no harm, is exactly why you'd use error reduction strategies like 2-tier verification to prevent administrative slip-ups. Justice means fair, equitable appointment scheduling for everyone. And your fiduciary duty? That's the bedrock trust of securing both physical and digital records. So ethics really isn't this abstract concept. It's what you are executing every single day.
All right, Section 3, architecting the medical office.
To uphold those strict ethical standards we just talked about, you're going to be actively managing some specific physical and digital spaces. The key here is understanding how data is organized hierarchically. You've got primary records, these are tied directly to active patient care, and secondary records, which are mainly for administrative use. And within these files, you'll be constantly organizing info using the SOAP note format. That stands for subjective, objective, assessment, and plan. So, for example, if a patient describes their own pain, that goes right into the subjective section. You are essentially the architect of this daily flow of information. But you aren't just organizing data, you're also architecting time itself. Let's look at a couple of scheduling rhythms. Stream scheduling, which is sometimes called fixed interval, assigns very specific individual time slots for your standard, consistent consultations. But then there's wave scheduling. This is where you assign multiple patients at the start of an hour. Why do that? Well, it's a lifesaver for high-volume clinics where late arrivals and, unpredictable consultation lengths are just the norm. You have to figure out and manage the architecture that perfectly fits your clinic's unique pulse.
You really see how this all connects when you trace the continuous medical office workflow. It's this uninterrupted cycle: pre-arrival, arrival, clinical encounter, and post-encounter. And your proficiency across these 4 stages is what solves interoperability problems in healthcare. You're the one connecting the dots, from verifying their insurance eligibility before they even step through the door, to managing clinical intake, right down to seamlessly filing their lab results after they leave.
Let's jump into Section 4, real-world process engineering.
Let's look at some actual crisis management with a pretty fascinating case study from the Metropolitan General Clinic. It shows exactly what happens when systems just completely break down. 35%.
That is a massive, alarming number. The clinic saw a 35% increase in patient wait times, along with a 15% jump in lab filing errors, and this was all over just 6 months. The root cause? Well, they were using this really inefficient open hours scheduling approach that was causing massive morning bottlenecks, combined with absolutely chaotic, unstandardized filing conventions. It was, quite literally, an operational nightmare. So management and medical records experts had to step in with a definitive process engineering fix. First, they scrapped those chaotic open hours and switched to modified wave scheduling to intelligently stagger the patient arrivals. Then, they strictly standardized all digital file naming to one single format, patient ID _ date _ document type. Simple, right? Finally, they implemented a really strict two-step verification for all outgoing referrals. And wow, the results just speak for themselves. In only 90 days, patient wait times dropped by 22%, and those dangerous filing errors, they plummeted to near zero. I think this perfectly illustrates the main thing I want you to take away from this. Secretarial work is absolutely not just paper pushing. It is literal operational process engineering. You actually have the power to repair broken systems. Which brings us to our final section, Section 5, Advanced Troubleshooting Tactics. Look, even the absolute best processors are going to hit edge cases, system failures, and unavoidable human conflict. To truly master the operations of a high-reliability organization, you have to nail the record management lifecycle. It's got 5 rigorous stages. First, creation, where you audit for accuracy and standard nomenclature. Second, maintenance, which involves using tools like encryption or color coding. Third is usage, dictating how the data is actually applied. Fourth is retention, meaning you keep files securely archived based on strict regulatory timeframes. And finally, disposal, which ensures the secure destruction of data under tight HIPAA safeguards. Now, during that usage phase I just mentioned, you'll be drafting some really vital professional correspondence, like a referral letter from a GP to a cardiologist, for example. You absolutely must adhere to the strict 3C protocol: clarity, conciseness, and correctness. You'll often format this stuff using the full block style, meaning all lines start completely flush at the left margin. That precision in your drafting is what ensures clinical accuracy and professional communication across the board. But hey, what happens when the digital architecture completely collapses? System downtime. The stakes here are incredibly high. If the electronic health record system goes down, you don't just send patients home or sit around waiting for IT. No way. You immediately engage the manual contingency plan. You switch right over to established paper-based registration protocols so that patient care continues without a single interruption. And of course, we can never forget the human element. Patients in clinics are often in a lot of pain, or they're highly stressed, which means tensions can run really high. To troubleshoot those difficult, real-world encounters, you've got to deploy the learn strategy. That means you listen to the patient, empathize with their situation, apologize for the inconvenience, respond constructively, and notify the appropriate personnel. Think of this as your critical psychological toolkit to de-escalate conflict and keep the clinical environment safe. So we've covered the ethics, the scheduling architectures, the process engineering, and the troubleshooting required for this incredibly dynamic role. But before we wrap up, I want to leave you with a provocative question, and this ties directly into your upcoming homework assignment for the medical record diploma. Based on systems theory, how does a single lost patient file impact the entire surgery department? Really think about that ripple effect. I want you to truly analyze your real-world impact as you move forward. You are the gatekeepers. Thanks so much for joining me in this explainer. Go crush that assignment, and I'll catch you next time.